Well, welcome everybody to the Still Healthy Today on the opiate crisis. Dr. Spolarich from our ASDO school will be speaking to us. She has a lot of experience and knowledge that she's going to share. This is available for Still Healthy credit. It will be loaded to YouTube afterwards. If you would like to share with your colleagues, keep in mind the Still Healthy deadline is still November 30th. So you want to get everything done by then. Welcome to our online viewers. So this is being broadcasted via Zoom. If you do have any questions, please repeat them for everybody so they can hear them. Okay, please welcome Dr. Spolarich.
Hi, everybody. Thank you. And thanks for everybody who's joining us remotely. So this is a terrific topic, and I certainly think we're all very familiar with what's happening globally in the wake of the opiate crisis. And of course, as most of us know, when here in this room, and of course in our distance audiences, we represent many professional disciplines, and virtually every professional organization has been working to put some type of clinical practice guideline or documents with recommendations for practice into place. And what I thought we could do today, instead of sort of rehashing what we know in our lives as professional people and as lay people, even being exposed to many national campaigns, I wanted to just kind of stop and take a look at where we are, where we have come from, because we get mired a lot in all the bad news, and there still is a lot of bad news related to opiate use. But I think we have made some progress, and we still have some room for growth and improvement. And I wanted to definitely take some time to talk about this today, but then to also hit on some other kinds of practice pearls that are maybe a little bit new and or a good refresher, in addition to what we all know is that we need to reduce the number of prescriptions that we're writing for opiates, and we need to be doing a better job at screening for when they are actually necessary, right? And when there may be better alternatives. And, you know, the danger in all of this is that we could also swing in the other direction where we never use opiates, and they do have their place in medicine, you know, in certain kinds of situations, but they certainly are not the one-size-fits-all intervention that I think they have come to be. So those are some learnings that I think we're all very familiar with, and kind of doing a better job at pre-screening our patients and taking a better look at the kinds of procedures we're doing and what kind of pain do we anticipate with the things that we're doing to our patients. And then also, many states now, here in Arizona, we became the 8th state in the country to have opiate prescribing guidelines that supersede all other guidelines that are discipline specific, meaning they are the umbrella guidelines, so all prescribers are to comply with those recommendations. And now many states have similar kinds of documents. In fact, the majority of states do, and I suspect within the very short future, you're going to see all states have these recommendations based on initiatives by the CDC in our respective professional organizations. So I will take a few minutes to go over those just to refresh everybody of what these recommendations are, because regardless of whether you live and practice here in Arizona, the rules are very similar, and what we find is that many states share their recommendations so that we have this, you know, lovely consistency with also what organizations like the CDC are promoting. So, and now my clicker is not working, sorry. So let's kind of take a little bit of a deeper dive here. Okay, we may need to get AV in here, so sorry. Okay. So let's take a look first at sales. I think we're all familiar with the fact that sales of opiates and the number of prescriptions that are being dispensed have quadrupled within just shy of about a 15-year window of time. And of course, Concurrently, we see the number of prescription opiate overdose deaths increase almost in a parallel fashion. But what's interesting about that is that there hasn't been any change in the amount of pain that Americans report within that same window of time. So the phenomenon of pain has not changed, but our prescribing behaviors have. And we know that there was a peak in prescribing patterns in about 2012, and it translates into the math as about 31 prescriptions dispensed per 100 people. But since that time, in the wake of awareness of opiate prescribing and interventions from a public health perspective, we have actually seen a decrease in the number of prescriptions. And I think that's a really good thing. The average now nationally is about 66 prescriptions per 100 people. However, in about a quarter of the counties in the United States, we still see prescribing rates that are very high. And in fact, in some counties, the rates are 7 times higher than the national average. In some of those locations, that equates out to be 1 prescription for every person who resides in the county. So I think it's pretty clear to see that we still have a lot of work to do. Now, this is a snapshot of states related to their prescribing patterns, and the darker the number, the greater the number of prescriptions dispensed. So this is data from 2012, and since we're in our AT still family, we can focus on Arizona and Missouri, and you can see that we are still, at this time in 2012, among the states that have fairly high prescribing patterns. And then if we fast forward to 2016, and 2016 is the most recent data we have, just so you know, prescribing data comes out annually, and it's usually released in May of every year. So we're just a few weeks shy of the 2017 data. It's always for the year before, right? What you can see is that while we are still higher than where we would like to be, so once again, kind of the darker the color, right, you still see high rates of prescribing. Our numbers are still, I think, higher than the national average, right, where we said we've come down to now about 66 prescriptions per 100 people. In Arizona, we're about 70 prescriptions, and Missouri, we're about 80 prescriptions. So part of this, I think, has a lot to do with access to care issues and people who are getting episodic care, emergency room kind of care, late in the day interventions, if you will, with many of the populations that we treat. If you collectively look at where the prescriptions land, right, about 1 out of every 5 people with non-cancer pain or pain-related diagnoses are getting prescriptions in office settings. Rates of prescribing increases among specialists who are much more likely to deal with acute and chronic pain. And none of this is rocket science. It certainly makes a lot of sense to us. And they're highest among those who work in pain medicine, in surgery, and in physical medicine and rehabilitation. And we certainly see an explosion in the number of pain management centers that are available nationally. They also tend to be clustered in certain regions where you see a lot of older adults, right? So Florida has the most. We see a lot in Texas. We see a lot of Arizona. We see a lot in California. Primary care providers account for about half of all of the opiate pain relievers that get dispensed in this country. For my dental colleagues who are here, dentists tend to write about 20%, right? So that's where we fall in relation to the other prescribers. And I think we're all very much aware of these statistics about the high rates of opiate overdose. Arizona has a very high rate of opiate overdoses, and that includes prescription opiates as well as heroin. And then, of course, at the same time, we see an increase in the number of people who are admitted into emergency departments, right, who are not using prescription opiates as directed. So they're either misusing medications. So we have, a literacy problem, or we have people self-medicating, or we have people who are using them recreationally. And you've probably all seen this chart or a similar one to it, where opiate deaths are high with any opiate compared to commonly prescribed opiates, now higher than heroin and higher than synthetic opiates like fentanyl and tramadol. I think you can see in this map, this is where we see an increase in most recent years of opiate overdose rates. And we see a tremendous cluster here in the Northeast corridor, as well as in Florida, Louisiana, and Washington state. And the CDC has been working on multiple public health initiatives to try to understand why is this happening, and do the numbers that actually get reported through our state health departments actually accurately reflect what is really happening in the states. And so in the states that had very high rates of prescribing and high rates of overdose, they have designated funds to study these patterns of overdoses and reporting mechanisms, and to try to capture that data more accurately and to get it sooner. And these would be the states that are green, that now receive federal funding to study this, and this is fairly new. And of course, our friends in Missouri are living in one of those states. And remember, we said that they're higher than the national average, about 80 prescriptions per 100. So that's going to be interesting to see what transpires over the next couple of years. So stay tuned to that. A couple of other things to understand is that we actually see prescription drug abuse vary a lot by age groups, by gender, and by ethnicity. And we know, and this often surprises my students when I teach them this, that older adults, and that's defined for this purpose, is 40 years and older, right? I'm just the messenger, don't get mad at me. Older adults are more likely to use prescription opiates than younger adults. And of course, you're talking about a lot of diseases with aging and more medical problems, more musculoskeletal problems, more surgeries, things like that. Women are always more likely to use opiates than men do. Women also, by the way, tend to use more medications than men do in general, because women tend to be the gatekeepers of healthcare in the family. And non-Hispanic whites are more likely to use prescription opiates than Hispanics. And there's no really difference between prescription opiate use between non-Hispanic whites and non-Hispanic blacks. Interestingly, women are much more likely to die from opiate overdose, and we are seeing a tremendous increase in the number of women who are ODing. Look at this, it's increased 5-fold. And it's directly proportional to the increase in prescribing of painkillers. They go together. And if you just look at the percentages of men and women affected, you can really see a tremendous difference in the numbers. And it turns out to be about 18 women per day who die from prescription painkiller overdose. And that, for everyone's knowledge, is much higher than what we see with overdose related to cocaine and heroin combined. So we see more emergency department visits for women, about 1 visit every 3 minutes here in the United States. And there are many reasons for this. Women are more likely to have chronic pain, to get prescriptions, to be given higher doses, to have drug-related adverse events, to develop dependency more quickly based on differences in kinetics. And then also, women are more likely to engage in doctor shopping. So everybody take a good look at me right now. Just, take a look up from your lunch, because I'm actually the face of the new doctor shopper in the United States. Not me literally, but women who are in their 50s, who are well-educated, reasonably well-groomed and articulate, who can actually score drugs pretty easily from providers. Because, whether we like it or not, everybody sort of has a stereotype of who we believe this drug shopper looks like. And we certainly don't think of educated, employed women as coming in to try to score drugs from somebody. And also think about older women who we know are also exceptionally good at doctor shopping. So this is a good teachable moment to share with our students and our colleagues, to remind everybody that you got to break out of that stereotype mold. Otherwise, you will have this experience with someone coming into your care setting. This just looks at drug overdose deaths among women. And again, here we are, and we're kind of in the second to highest strata of women who die from opiate overdose. Now, this is kind of a tough article to read, a tough slide from where you're sitting, but it also helps us to not only recognize that women tend to be doctor shoppers, but also that people who are kind of the outliers in terms of the people you're least likely to suspect as being doctor shoppers. We're able, this was an interesting study that was done among 10 different prescribers. These women were able to get 32 opiate prescriptions. And of course, now with electronic health records, it's getting harder and harder to do that. But people are really good at doing this. Yes?
So you're saying that there's like one prescription per person in some of these
In
states.
some of the counties, in some counties, right.
But I'm wondering what fraction of the population that actually includes, since you might have one person with 32 prescriptions.
Right.
So I mean, is it, I'm wondering, do we have any idea what the overall percent of the population who get any prescription could be?
No, and it's going to be, oh, so excuse me, for those of you joining us remotely. So the question is, you know, recognizing that in some of these counties where we could be getting as many as one prescription per person in that county, you know, do we have really any understanding of, well, how many of those people are the drug shoppers who get a lot more than one? Are they kind of throwing off the curve, if you will? It's been hard to study up until this point now. With electronic health records, it's going to be easier to figure that out, right? Because you can now, if you are a participating pharmacist in one, like SureScripts, for example, where that links data to about 70,000 pharmacies in the United States, you would be able to tell whether people got drugs, you know, in Pennsylvania and Alabama and Montana and Missouri, right? When they're sitting in your chair. It's been tough to track that so far, right? So I would be remiss if we didn't take a moment to just talk about kids for a minute, because prescription drug abuse, as we all know, is a tremendous problem in children. Kids today are using prescription drugs recreationally much more so than any other street drug combination that's out there. And just to kind of let you know, kids with high anxiety are more likely to seek downer drugs, are going to be more likely to look for things like opiates compared to kids with low self-esteem, which are looking for uppers or stimulants, right, for self-medicating. And a lot of this data that I have on this slide comes from the Monitoring the Future study, which is funded through the National Institutes of Drug Abuse and is conducted through the University of Michigan. I think they are now in their 45th year. I mean, it's been an incredibly robust data set to look at, collect anonymous data in 8th graders, 10th graders, and 12th graders, and they report on all kinds of information about drug use. And what I want everybody to understand is about 1 in 9 kids between the ages of 12 to 25 have used prescription drugs non-medicinally in the past year. And about 25% of kids who actually started using prescription drugs prior to the age of 13 will actually meet clinical criteria for addiction at some point in their life. And these are pretty scary statistics. And what I want you to see is, you know, Vicodin always comes up high in the list. And then, of course, we have OxyContin, which almost always makes the list as well in the context of opiates today. And again, you know, this idea of what we call farming, it's a phenomenon in kids, is where they're just going home and raiding the medicine cabinet, and they take what they can find and they take it to school or they take it to a party, they throw it in a bowl, they take some and they see what happens, which is how kids end up in the emergency room. And so when we look at the context of what we're talking about today is, as prescribers, it's why we have to limit the number of not just prescriptions, but the number of tablets, right, or capsules in each prescription, because we don't want people to have leftovers and have them hanging around and create this opportunity. So hydrocodone with acetaminophen is the most abused prescription drug by teenagers in the United States, right? So what's in the medicine cabinet? Everybody needs to do a little bit of a self-assessment with that. And access to medications at home is the leading contributing factor for kids who end up going to the ER due to accidental or intentional overdose. 90% of addictions start in teenage years. 1 in 6 teenagers have used medications to get high. About a quarter of teens, but only about 16% of parents believe that using prescription drugs to get high is safer than getting high on street drugs. So clearly we have some educational opportunities with these kids. And of course, opiates always make the top 3 of substances that kids like to abuse. And here's just another slide. This is in 12th graders, where you see Vicodin actually moves up the list, as does OxyContin. Kids today are saying that it is harder to get these things on the street but it's easier to get them at home. They don't have to go to this street anymore, right? Because these drugs are so accessible. And this is a very difficult slide to read. It's a snapshot out of Monitoring the Future study. And the reason I bring it is just to show you, they ask kids, where are they obtaining drugs, right? And interestingly, across the board, what you'll see, by and large, the majority of kids are getting them for free by a friend or a relative, followed closely by buying them from a friend or a relative, right? So we have eliminated the need to go out onto the street. And then if you look at similar data that is collected by the CDC with adults, the gray bar represents given by a friend or a relative for free. And these are, of course, increasing with a number of days in the past year of using non-medical use. And again, the trend is the same, right? You don't have to buy them on the street anymore. You can get them very easily. So let's move from kids now and talk about adults, because geriatric addiction is a tremendous problem in this country. It is a very, very real problem in this country. And a lot of these folks tend to slip under the radar. When we look at what substances are abused in older adults, nobody should be surprised at what's here. Benzodiazepines, they're prescribed a lot for anxiety and for sleeping pills, and they don't really work as sleeping pills because you develop a tolerance to them. But opiates, come into the second slot. And then, of course, here's alcohol, which nobody even thinks about as a drug, but alcohol and opiates and alcohol with any of these drugs doesn't mix. And alcohol use tends to increase with age, especially in the immediate years after retirement, and then sleeping pills, right? So dependency on prescription drugs is multifactorial. I can tell you from, sort of working in geriatrics that almost always it starts with a legitimate medical need, right? It starts after a major surgery. They get their opiates after a fall and they've broken a hip, or they have a joint replacement surgery. So it's a legitimate medical problem, and then they will keep going if they have chronic pain, and or when they recognize that the sedative properties of opiates, hey, help me to sleep better, because as we get older, insomnia tends to be a major problem with older adults. So you kind of get a 2-for-1, and why we might like that following a surgical intervention with a patient, people learn from that, and then they recognize their benzodiazepine doesn't work so well anymore. Hey, I have some of those Vicodins left over, and they start self-medicating for another problem. And they'll use it also for anxiety and depression. But other things that come into play here are loneliness and boredom. And here in Arizona, we have a lot of people who either came here as younger adults and when they first retired and they were very active and enjoying life, and then something happens, right? And now their lifestyle has really changed. Maybe they're no longer independent, or they've lost a spouse or a partner. Or conversely, they were happily living, in Wisconsin or Minnesota or in Canada, because we have a lot of Canadians here too, whose children move them here because it's hard on the kids to go back and forth when mom and dad are having health problems, and they get relocated for the convenience of the adult children, and mom and dad are suddenly not doing so well anymore. So there's many, many factors, and I wish we had more time to go into that, but it is important to look at this problem also from a psychosocial health perspective, right? We see this particular problem in older adults pretty much every single day in our clinical facility here on campus. And this is the problem, what we call redundant prescriptions, where people are taking the generic name and the brand name of the same drug at 2 different dosages from 2 different providers, and nobody's recognizing it. And we have a lot of patients, don't we, who come into our facility who are not just on one opiate, but multiple opiates. And then we're going to do a dental procedure, and they want a prescription for a pain reliever, right? And they already should be well stocked and loaded up, locked and loaded with what they have. And this is a really good reason why in our state, there's a big push for people to have what we call an opiate home, right? Where one provider writes for the opiates for all indications. Somebody's the gatekeeper and maintains that to try to prevent this from happening. But redundant prescriptions is a tremendous problem. So I want you all to be kind of thinking about that when you're screening, you know, your loved ones or, you know, patients that you're caring for, and helping our students to understand how important it is to look up medications they're not recognizing the names so that they can pick up on this type of problem. And then also in older adults, you know, lots of times because of the sedative effects of being on opiates, you know, we will often excuse some of the cognitive effects that we see in that individual, say, oh, well, that person's getting older, that person's declining, you know, not quite with it anymore. Like we always have reasons that we kind of label somebody that are not appropriate. So it's hard many times to distinguish those effects from the effects of the drugs. And why are people getting opiates in older adults? Joint pain, sleeping problems, injuries from falls are kind of the big ones. But of course, we also see them with chronic cancer pain, things like that. About 20% of people over the age of 65 take analgesics multiple times per week. And we see rates of abuse and addiction in those with chronic pain around 18% of affected individuals. We also see distinctions by age in the category of older adults. There's really 4 age cohorts in older adults, but kind of the rule is the older the person is, the more leery they are of taking medicines and are more likely to just kind of want to tough it out, versus the younger the person is. And those of us who are baby boomers, right? We're the generation of the 60s, and about 1/3 of baby boomers have never stopped being recreational drug users, are going to be much more likely to welcome drugs and to use drugs, right? So just important to kind of remember those population differences. And then when we look at depressants versus stimulants, of course, opiates, once again, dominate the list as the most common prescription drugs that are abused by older adults. And again, even in this generation, more common than all street drugs combined. And just like younger people, kids and younger adults, older adults get drugs from well-meaning friends and relatives because, you know, you don't throw anything away. Right. So if you have some left over, just like you share your food and your clothes and your other things, you share drugs. And this is another opportunity for good education, right? So I think some other challenges we have when we assess our patients for risk behaviors and patterns of use is that many times assessment tools are written for young adults and they don't always translate well to different age groups. And so we do have some challenges, and especially as we're working with older adults, that once again, signs and symptoms get misinterpreted as products of normal aging, and this whole issue of polypharmacy adding to the mix, and then the fact that physiologically our body changes with age, and that we don't metabolize drugs as efficiently, we don't clear drugs as efficiently, then throw on some comorbidities that affect the liver, that affect the kidneys, that affect the gut, and you know, people tend to accumulate drugs, and you have more issues and challenges in older adults. So it's a rough ride often to try to figure out what exactly is going on with the individual, especially if they are poor historians. But the other side to this story is that clinicians tend to underestimate the level of risk for prescription drug abuse in older adults, especially in people who have chronic pain. Because we certainly don't want people to be uncomfortable. We want them to have good function and good quality of life. So then we run that danger of like, are we doing a good risk assessment? And then could we also then go in the opposite direction where we don't have people have good management of their pain, and then they have negative quality of life from that as well. So it's a fine line, I think. So some factors that increase risk for drug dependency: sadness over losing a loved one, being far away from family, and then even tightening it down further specifically to opiates is if you have a family history of abuse. And now current practice guidelines all recommend that we screen every patient for a history of substance abuse as an individual and within the family. Cigarette smoking, history of mood disorders, especially depression, being a younger, older adult, like a boomer. And this is a really interesting one, having a history of childhood sexual abuse. And the older the individual is, the less likely that person will have disclosed a history of childhood sexual abuse at any point in time. And in fact, this comes back into discussion in end-of-life care, right, where people self-medicating because they've never discussed the problem and never gotten help for that. History of drug-related problems, including driving under the influence and being unwilling or resistant to engage in monitoring programs. Some signs that we have moved now to an abuse disorder is missing appointments, requesting specific meds, occasionally increasing dosages on their own, getting medications from other sources, and us getting complaints from the patient about needing more medication. So, you know, I sort of pose this question to everybody philosophically to be thinking about is, should we actually be using opiates in older adults? And it's quite the debate. We know that we have much more likely problems with cancer and other non-cancer causing pain phenomenon in these individuals. And we know that they work very well for people with persistent pain syndromes. And that becomes that function and quality of life conversation. But then you have to look at appropriate choices, monitoring how well the medication is working and managing side effects in this population with risks for dependency, right? So remember, in an older adult, if we're using them, we're trying to really get function and quality of life. Interestingly, in older adults, what we see that opiate users have much higher rates of fractures, cardiovascular problems, hospitalization, and death relative to other types of pain relievers or other types of medications, including over-the-counter pain relievers. And people who are chronic users of oxycodone and codeine have more than twice the risk of dying within 30 days following the issuance of the prescription. So there are some other considerations as well. In general, however, pain management in older adults tends to be undertreated in this country, which I think is a surprise given everything that we talk about. So, and again, you have to weigh so many different kinds of variables in making that decision. And of course, the other place this comes into play is in end-of-life care. And for those of you who have ever been on that journey personally with someone in hospice care, you know, I love people who work in hospice. I think they are the greatest people on earth. And I've been through that journey with my own mother. So I have a high value for hospice care. But I think we have to look at when you assess pain, the intensity, how well the person responds, but also that the person gets to weigh in on how that pain is influencing them in many different domains of their life, right? Just one kind of comment too, which is a little aside. There are rarely any other occasions in life when there will be more what I call drugs of opportunity in the household than when someone is going through hospice at home. And we do have to remember that, you know, there are going to be opiates and other types of scheduled substances that are there. And it is a temptation for family members to, you know, one for mom and one for me, right? And there is a very high risk after the loved one dies that if people have been sort of siphoning off some of those medications, if the loved ones are not coping well with that event, there is a risk for suicide using those medications. And this is something, it's certainly not a pleasant topic to talk about, but I don't think we talk about it enough. And I know in dentistry, we never talk about it. I actually know somebody whose father committed suicide 2 weeks after her mother passed away. And those of you who've been through hospice, you know that as soon as the individual passes away, the hospice nurses come and they do a pill count and they remove the drugs from the house. And they do that immediately, whether the person dies at 2 in the afternoon or 2 in the morning. And it's for this reason. But also, I say this because I think you can never have enough eyes on this situation. And even with our patients, you know, who might be, you know, have a loved one who's going through hospice care, you know, these individuals, you get a read on it, you know, to make sure that they understand there might be risks with helping themselves and self-medicating. It's an important teachable moment. Some other kinds of things to talk about with opiates, of course, is when we prescribe for them, we have to also weigh all of the side effects that go along with them. And some people will be able to tolerate them better than other people will. And then, of course, if you have multiple comorbidities, it becomes perhaps a little bit more challenging. So, for example, in older gentlemen who have enlarged prostates, many times maybe we're not thinking that opiates increase urinary retention, and that could really throw an older gentleman for a curve, right? Especially if someone's sharing their medication with him and it hasn't been given to them legitimately. And then, of course, the big age-old problem, as we know, is with constipation. And so many people in the United States are constipated because they're sedentary and they don't drink enough water and they don't have a good diet. And people run into problems quite quickly. So I think anytime we're teaching our students, these are important things to review, to talk about, and weigh them with drug selection criteria, right? Do we really need that opiate? Lots of drugs increase risk for falling. Here at ATSU University, we have a tremendous interest in falls and falls prevention. And of course, it's very timely to just remind everyone that opiates make the list of drugs that increase risk for falling, right? Because of their central nervous system effects. Also, recommendations are that we never concurrently prescribe benzodiazepines with opiates because of the additive central nervous system effects, and especially when you're using higher doses. People can get into trouble, much more likely to be at risk for respiratory depression and overdose. And remembering too that people don't always know what medication, right, falls under these families. And older adults, very compliant with following directions, and we have to just be quite mindful about trying to avoid this whenever possible. And does everybody know what the Beers criteria are? Beers criteria? This is a list that was just updated about 18 months ago. 3 lists of medications that pose potential risks that outweigh benefits in people who are 65 years of age and older. And it kind of rates medications as inappropriate because there's either high risks of adverse effects, they don't work as well in older people, and there's maybe better alternatives. And so when you look at meds that are inappropriate, it's because they will likely exacerbate health problems, or they have to be used with caution because the risks outweigh the benefits. And look at this, opiates are on the Beers criteria. They are to be avoided in anybody 65 years of age and older, as are benzodiazepines, specifically for all the reasons why benzos are prescribed for older adults. And a lot of people don't know this, right? So, and I can tell you, I'm sure every discipline has stories of when we might do both of these drugs at the same time. Back in 2014, when Arizona was developing our opiate guidelines, I was one of 2 people from the university here who was part of that committee that was talking about, this phenomenon and what kind of rules should we put into place. And there were 3 of us from dentistry, 178 people from medicine. And in dentistry, we often will give a benzo for dental anxiety or use it as a part of conscious sedation, and then use an opiate for postoperative pain. And so we were really quite challenged with the never ever do this rule, which is what our emergency room physicians really wanted here in Arizona, because they said, we're tired of cleaning up everybody's mess. So I think we have to be better at this specifically in our discipline of dentistry, but it's a good rule for everybody to remember across the board. And I think we're all very familiar with recovery programs that are available for opiate dependency. Just to kind of let everybody know, buprenorphine is kind of one of the newer agents that's being used in recovery programs. It's used because it does a really good job at relieving cravings without the high. Like methadone, which you think of primarily as for heroin recovery programs, tends to kind of take the edge off and dampen the, the craving that you get from the dopamine surge when you use drugs of dependency. It tends to dampen it a little bit better, and it has fewer dangerous side effects. So we've certainly seen an increase in the number of patients we see in our facility who have gone through recovery programs using this particular agent. So just like the problem has grown, so too have the alternatives for treatment. Also, everyone should remember that people who have been using opiates, especially by injection, are at high risk for infectious diseases and related outcomes. So we often see higher incidence of Hep B, as well as Hep C, by the way, HIV infection, and then of course the potential risk for damage to the heart valves. And so for these individuals who are going to undergo invasive procedure, whether it's in dentistry or in some other type of domain, an invasive medical test, they may actually need to have an antibiotic on board prior to that. So these individuals may require a cardiac workup to determine whether or not there is valve damage. How's everybody doing so far? It's kind of warm in here, right? So just kind of thinking a little bit about why do people have so many of these things at their disposal? It's because no one knows what to do with them when they have the leftovers. No one knows how to get rid of extra medications. Now in our state, we are very fortunate because in every police station, we have boxes that are drop-off locations, no questions asked, where people can take their medications. But a lot of consumers don't know about that. They don't know what to do, and so they just hang on to them. And that, of course, creates an opportunity for kids to get their hands on them. So it is important to dispose of meds properly to prevent poisoning, deter misuse, and health problems from accidentally taking the wrong drug or too much of the same or taking one that is expired. And it also, if you use proper disposal, it has an environmental impact potentially. Now, first choice are drug take-back events, and the Drug Enforcement Agency actually hosts drug take-back events on a regular basis. You can go onto the DEA's website, you can just Google drug take-back, and you can type in your zip code where you live and it will tell you the date and the location. The other part too is, you know, lots of communities, little community where I live in the northern part of the county. I think it's the fourth Saturday from 9 to 12 in the parking lot behind the post office. The county sets up a little thing you can drive by and drop off your meds. So if you want to know what's available where you live, especially those of you who are joining us remotely, you can contact the county or you can just go onto the Drug Enforcement Agency's website. Pharmacies also have take-back programs. I actually asked my pharmacist if I could take a picture of this at Safeway, and she said the problem is people don't use it because it costs $3, right? So nobody wants to do that, right? So, and you probably don't have to do that because you can find a local program where you live. If you go on to the FDA's website, the Drug Enforcement Agency's website, there's lots of ways to explain how you can safely dispose of medications. And you can put drugs in incinerated trash. You have to seal the container, obviously take the label off. You can't take the label off, use like a black Sharpie on it to cross out your identifying information. You probably all heard how you can make it unpalatable by mixing it with wet cat litter or wet coffee grounds, all of these kinds of things. And this is an example of the document that you can get from the FDA. And it's actually really well written and very, very nice. And so those of us who work in clinical facilities, this is maybe some kind of information we'd like to have available so that we can share it with our patients. But believe it or not, some drugs should be flushed. And now that's not for professional people. It is only for consumers, right? So if in our clinical facilities we have these substances and they've passed their expiration date, we actually have regulatory programs that are monitored via the Drug Enforcement Agency of how you ship things back through a designated distributor. But opiates are on the list of drugs by the FDA that are supposed to be flushed down the toilet. And that is because the danger is a single dose in a child or even in a pet can be fatal, right? So your patient is going to ask you stuff like that, right? Here, of course, we're very fortunate. We can tell them to go to the local police station and they can drop them off there. So in our last couple of minutes together, I wanted to just kind of go through some current recommendations, what's available to us. You can access these online. Here are the CDC's recommendations. So they want everybody to use responsible prescribing practices and to first screen and monitor for substance abuse in your patients and a history of mental health problems. And of course, we want all prescribers to engage in your state's monitoring program. So here in Arizona, we had a designated date last fall where people were mandated to be enrolled in the prescription drug monitoring program. That, by the way, has been available for a long time, but there typically were not a lot of funds to enforce whether people or not were actually using it. Our state's program has actually undergone a big overhaul and making it a lot more user-friendly, because one of the big complaints why people weren't using it was a little bit challenging to navigate. So if we're going to mandate people to participate, we have to make it easy to use, right? And then we also have to recognize there's other ways to manage pain besides opiates, and not all pain is the same. And, you know, you got to love ice, you know, it's a good thing. I teach pharmacology, but I love non-pharmacologic things, right? Rest and ice and elevation and all of these other kinds of things. So just maybe expand your horizons a little bit about what else is out there. Discussing risks and benefits of painkillers with patients, especially when they're asking for them. Recognizing it may worsen some chronic health problems, and they should be avoided during pregnancy. The risk truly has to be beneficial to the mom, and that risk has to you know, be minimal in the baby, right? So mom's benefit has to outweigh the risk to baby. Avoid prescribing combination benzos with painkillers, and there has to be a pretty darn good reason if you're going to do it, right? And whenever possible, remember, NSAIDs tend to be our preferred agents. So much pain is inflammatory in nature, and opiates are not anti-inflammatory. And of course, you have to make sure that the person can use NSAIDs. There's no drug interactions. They have good liver function and good kidney function. All opiates will cause nausea in most patients. You have to let them know, as is constipation, and what to do about it. One of my friends in the PA department said, "Hey, Ann, how come dentists don't know that patients should take Colace or another kind of stool softener anytime you're writing for opiates?" And I said, well, I don't know, but I'm going to start teaching that now, because that's a really great recommendation. And also, I tell patients to eat a lot of whole fruits and vegetables that have a lot of fiber in them, right? It's a great way to help to naturally combat that problem. And then we talked about all the reasons why this is even more challenging in older adults. But also remember, watch for those central nervous system effects, especially in older adults. They will be additive with so many other things that they're taking. Risk for falls, disorientation, drug interactions, etc. So the net effect is we all have to stop over prescribing and limit the quantities when we do. Then for just a few moments, I'm going to take you through the Arizona guidelines, and I'll show you the Missouri ones in just a minute too. But they should only be used when the treatment of acute pain is, you know, severe enough to warrant that choice, and when something that is a non-opiate is not going to be effective. And when we write for them, the number should be no more than what that person really needs. I know in dentistry, we're trying to limit it to just like 3 days only. And then if somebody really legitimately needs more, we re-examine the patient, and maybe they are going to get more legitimately, but always, you know, kind of limiting that pill count, if you will. When they are prescribed for acute pain, counsel the patients. They have to know that sharing opiates is illegal. It is in fact a felony. That's called drug diversion, and it is punishable. Medications have to be stored securely. They should be disposed of properly, and they're only supposed to be used for short-term use, with that caveat of people who may be using them for chronic cancer pain or a few other chronic conditions. And to remember that you are impaired when you're on them. So being careful when, you know, not to drive or use machinery. Long-acting opiates should not be used for the treatment of acute pain, including post-operative pain, and should only be used when people are what we call opiate tolerant, or when we can closely monitor that patient. And continuing use should be considered carefully, including the risk assessment for misuse and then dependency. And then you should participate in the state's drug monitoring program. So it's pretty easy to see how these guidelines get tweaked by state, because everybody sort of feels the same way. So for our friends joining us from Missouri, Missouri now has a document as well. It came out in January of this year, and you can download this for free, Controlled Substance Guidelines for Missouri Practitioners. So just like we have guidelines that supersede and go over all disciplines of prescribers in Arizona. You have the same thing in Missouri. So I would strongly encourage you to look at this. They have a lot of the same information that we've been discussing today. And some other good news is that we do see opiate rates really starting to come down as a result of these individual state guidelines that have been put into practice. And last but not least, and then I'll take 5 minutes of Q&A, HE Still University has a policy in place for our drug-free and alcohol-free workplace. And we have opportunities to read this policy, to get assistance in our workplace. We are very fortunate, but we do recognize that certainly drug dependency is an illness. It is a treatable illness, and we want to help people and connect them to the right resources if people have a problem. And so if it's been a little while since you've looked at our policy for the university, this is a golden opportunity now, because we have this discussion front line in our minds after today's Still Healthy. So with that, I'll ask if anybody has any questions for me. Ted?
And a couple comments. The new recommendations for Arizona came out yesterday, and it's important for healthcare providers to recognize that in 8 days there are new regulations regarding the magnitude, the size of prescriptions. I think there's some information in there about e-prescribing.
Yep.
So we really need to tune into that.
Okay, so thank you for that comment. Yeah, I really should have done this a week from now. So Dr. Wendell's comment is, here in the state of Arizona, in about a week's time, we have new guidelines, updated guidelines that will be put into place. And much of the content that we talked about today is in those guidelines, and there are some extensions about e-prescribing for opiates, because, for a long time, while you might be able to use e-prescribing for other kinds of medications, controlled substances in the past were not a part of that, and now they will be, but everybody should understand what the rules are and how to work for that. So be on the lookout for that. And then, of course, for our faculty who are joining us from Missouri and other remote places, you want to be always aware of what the most current guidelines are in your state. So that's a great comment. Erwin?
Why is oxycodone with acetaminophen more problematic than hydrocodone with acetaminophen?
Okay. Yeah, so the question is, why is oxycodone with acetaminophen kind of more problematic than hydrocodone with acetaminophen? And it's because of its potency. It's because of its potency. Now, oxycodone also has some variations that are extended release formulations. And for a long time, it took a long time for the FDA to approve them. There was like the great debate as should we really even put these drugs out there, because the potential for abuse was very high. So the core of the drug was sort of centered in the middle of the caplet, and what people who would use them recreationally would do would take them and they would crush it, and they would get that concentrated dose sort of all at once, right? Now the manufacturers of those, if you break them, the center part actually kind of turns into this gelatinous goo to try to make them abuse deterrent. But if you are someone who wants to prescribe extended release, you actually have to have separate training and a permission, if you will, in order to be able to write for those kind of drugs. And then you get monitored for that behavior as well. It's with that application. But oxycodone is more potent than hydrocodone. Yes, Ted. I'm sorry, did you have a question too? Did I jump? Sorry.
Yeah, the previous slide, you said that you felt the new policies that caused the decrease.
Mm-hmm.
That's what I wanted to say. I was so fast.
Sorry. So these are states.
The dark lines are the ones with new policies, the dotted.
Right, right.
That's the note about the
These are the states that have implemented specific recommendations, and they've been very proactive in their, yeah. Right.
What are the light gray lines?
So what you're looking at here is dispensed prescriptions across all retailed pharmacies. So actually, this is just a snapshot of, there's a larger database that's here about sort of where they started and then what has happened in prescribing trends as a result of them implementing these programs and recommendations. Ted?
The missing link to all this is manufacturers.
Right.
We can do all that we want to do in terms of, use, but just because you can produce something doesn't mean you have the right to sell it. Sending, hundreds of thousands of doses into communities that only have 1,000 people is morally irresponsible. It should be illegal. So we really do need to pass for some sort of legislation.
So thank you, Dr. Wendell. Dr. Wendell's comment is that, the manufacturers have a role in this solution, if you will, right? And that they are, they're putting a lot of stuff out on the market. Should they really be allowed to be doing this and making so many drugs available into communities, right? Where I'm paraphrasing for you. I should have given you the microphone. But I think it kind of ties into, you can't just look at this program from one perspective, this problem from one perspective, because, we also know that one other big outcome of this is heroin use has gone up, because heroin is now cheaper than trying to buy prescription drugs on the street. So it has many, many, many implications. We only have an hour today. It's just really a snapshot. So, Mike. So Mike's question is a very good question, is are we seeing this epidemic in other countries? Well, first of all, no one uses more drugs than Americans do. So I would say North America has a problem. Australia has a problem. We see this in parts of Asia, obviously in industrialized countries you see it, but Europeans tend to not use the same amount of drugs that we use. So it is kind of specific. And of course, remember too, we have direct-to-consumer marketing in the United States, right? And a lot of countries feel that it's inappropriate that we sell drugs, directly to consumers and in magazines and on television and things like that. Well, thank you, everybody. I appreciate you coming, and thanks for your kind attention. And thanks, everybody, for joining us, and have a great rest of your day. Thanks.